怎么这么特别？发生了什么事？这个是我是还没有看吗？看了没签名啊？等一下再确认一下，应该
但你有写字，
对啊，怎么会这么奇怪？
我只是有2个可以同时看。
啊，所以我还没看完吗？我已经写了，我以为我已经看完了，太诡异了哈。So the first case is from a 96-year-old male, so a very old male, who had a past history of urinary bladder high-grade urothelial carcinoma. So this is his urine specimen. So first thing is that the specimen is not very cellular, and it shows significant drying artifact. However, I think we do recognize some of these cells shows that prominent enlargement of the nucleus and high NC ratio. The chromatin pattern is not very easy to recognize, but you still can sort of tell that it can be some more like a coarse hyperchromatic pattern. So again, we do see some more bland-looking cells in the background. So this is lymphocyte. So recognize the size of the cell. This is like slightly larger, but these two are like significantly bigger than the relatively normal lymphocyte, and with a very irregular nuclear membrane. So overall, I think we do have a lot of these atypical cells, some with more like a preservation of the chromatin. Some show significant drying artifact, but indeed majority of the cell in this specimen looks very atypical. And the patient also had a past history of high-grade urothelial carcinoma. So I think we can just call this positive because we have enough cells, and this is highly irregular, angulated. So we call this high-grade urothelial carcinoma. The next specimen is from the pancreas EUS guided aspiration. So the specimen has been obtained through the duodenum. So we do recognize there are some like a typical cell with vesicular chromatin prominent nucleolus and significant polymorphism. In the background, they do show some necrosis pattern as well. So you see cellular debris. So this is positive. I think most of the cells have these adenocarcinoma feature. So again, enlarged nucleus, vesicular chromatin, and prominent nucleolus, and with cytoplasm like evacuation. Some of the area does show these intestinal type arrangement with stratification. So this is positive for adenocarcinoma. So the next specimen is from the pleura effusion. The patient had a past history of lung adenocarcinoma. We have confirmed it with TTF1. So this is a new patient who just visited our hospital at this admission. So we had a prior specimen we've already tested for TTF1, which is diffusely positive. So this is the second specimen from the same patient. So we also see like high disease burden. Most of the cell here are adenocarcinoma. If you take a look at the cell block preparation, again, most of the cell looks like adenocarcinoma. So this is positive for adenocarcinoma. The second case, the patient has been treated for lung cancer for a while, so this is compatible with recurrence of the disease. And you can see the nuclear TPI is high grade. This is larger and more prominent nucleolus, and some more single cell in the background. So this is compatible with recurrence of adenocarcinoma of lung. So the next specimen is also a pancreas EUS aspiration. So it is moderately cellular. In the background, we do see some intestinal mucosa contamination with this nice honeycombing pattern, some luminal border at the edges. Here is the non-neoplastic pancreatic acinar. So you can see there are nice organized acinar pattern. So we do see some non-neoplastic normal elements. But in the background, we also see some really monotonous cells with moderate or scant amount of cytoplasm. The cell nucleus is very uniform. It's mostly rounded. And if you take a look of the chromatin pattern, this is the classic salt and pepper chromatin pattern. So we have small solid nest with loosely cohesive, a little bit individual single cell, some with enucleation. And the cell is very uniform, showing neuroendocrine nuclear-like feature. So this is highly suggestive of a neuroendocrine tumor of the pancreas. So we will wait for the immuno result from the biopsy, from the concurrent biopsy. So this is just by morphology, it is mostly compatible with a neuroendocrine tumor. The other differential diagnosis for pancreatic neuroendocrine tumor includes solid pseudopapillary neoplasm. Usually the cell morphology will show less prominent chromatin pattern of the neuroendocrine, and sometimes you can see the pseudopapillary pattern that you will see a fibrovascular core, and with tumor cell loosely attached to the vasculature. The other differential diagnoses also include acinar cell carcinoma. Usually you will see more prominent nucleolus, but sometimes the nucleolus is very difficult to identify. But this is most common. I think the best diagnosis for this one is pancreatic neuroendocrine tumor. And we will wait for the immunos. So finally, there were a couple salivary gland aspiration. The first one is from a 75-year-old male with parotid tumor. So in the background, we see some degenerative, cellular debris with some inflammatory cells. And some histiocytes suggest that it is a cystic, a fluid. And we do recognize very scant epithelial cells. Looks very bland looking, organized arrangement, honeycombing, and with abundant granular cytoplasm. So these looks like oncocytes. So with inflammatory cystic background, with a granular degenerative debris, as well as benign looking, nice, a flat fragment, cohesive fragment of oncocytes. This is most compatible with Warthin tumor. We have very, very scant cellular epithelial component in the liquid-based cytology, but in the direct smear, we have a lot of oncocytic epithelial fragment. So this is a benign salivary gland tumor, and this is a wasing tumor, which most commonly occur in the elder male who is a smoker. So this is compatible with the case's clinical finding. The second case is even older. This is 92-year-old male, also parotid mass, which is a cystic mass. So again, we find very prominent cystic, like a fluid background with a lot of degeneration, cellular debris. We do not see any epithelial element in this specimen, but the content of this cystic fluid is very likely to be the content of a wasing tumor. So usually for this situation, I would order a cell block preparation for the residual liquid-based cytology specimen. If we sometimes we can identify larger fragment that was not presented in the cytology specimen. So if we identify any of these oncocytic epithelium, we would just directly call it wasing tumor. If we don't, we would just call these non-diagnostic, Milan category 1, and we will address that the background is compatible with the content of the wasing tumor, suggests clinical correlation. So there's only very tiny fragment. It is a little bit uncertain if it's a real oncocyte or it can be histiocyte because there are some reactive changes. So let's do a cell block on this one to check if we can find more. So the final specimen is also from the parotid, and this is one of the most common tumor that we will see in the salivary gland aspiration. So on low power, you already see there are a lot of chondromyxoid matrix in the background. And this matrix is closely associated with these spindly oval-shaped myoepithelial cells. In the background, there are a lot of like a single or loosely cohesive oval spindle-shaped cells, which is also myoepithelial cell. So this is a myoepithelium-rich tumor with a chondromyxoid matrix and with a fibrillary texture. So this is a polymorphic adenoma. In the polymorphic adenoma, we would like to see sometimes some ductal component. I think these are still myoepithelial cell, more cellular. These might probably be ductal component. So we see ductal, we see myoepithelium, we see matrix. So this is good for the diagnosis of polymorphic adenoma. Here we also see some non-neoplastic acinar cells, which looks very similar to the acinar cell in the pancreas. For the diagnosis of polymorphic adenoma, here is also some ductal component. We would like to confirm that there is no cellular atypia because there is a possibility for carcinoma arising from polymorphic adenoma. And all of the cell here looks very bland looking. And when we diagnose of polymorphic adenoma, we like to see loose stem, which has very good contrast for this chondromyxoid matrix. And you can see this very delicate, like a fibrillary, feathery type of like texture. And remember, this type of matrix is closely associated with the myoepithelial cells. So this is a good case of a polymorphic adenoma. So that is all the case for today.